All right. Good morning, everybody. My name is Zachary Gertz, and welcome to Cardiology Grand Rounds at VCU. This morning we have two speakers, two of our first-year fellows, and it is my pleasure to introduce our first speaker, Dr. Harika Yadav. Dr. Yadav completed her medical school at JN Medical College in India and graduated from the Global Health track. She did her internal medicine residency at the University of Tennessee in Chattanooga, actively participating in QI and research projects aimed at enhancing equity and accessibility of resources for patients with cardiovascular disease. Her professional interests within cardiology focus on global and rural health, and I am pleased to present her to give our first talk. Go for it, Harika.
Thank you. Thank you, Dr. Hertz. Oh, that didn't do it. All right, sorry, 1 second. Hi, everybody. I wanted to start with a story on why I chose this topic for Grand Rounds in the first place, because I know it isn't something we commonly see here, but I recently met a patient who is a 28-year-old female, grew up in the same place that I did in India, and moved to US to pursue her master's in computer science when she was around 23 years old. Over the course of her master's degree, she started having progressively worsening dyspnea, and she assumed she was just adjusting to the cold weather of Minnesota until the symptoms started getting worse. She initially went to see a primary care provider and then later a cardiologist who told her that she was young and that it was likely deconditioning and she just needed to lose weight. So she slowly developed worsening dyspnea even on climbing a flight of stairs. But with everyone reassuring her about her age, she told me, I thought everyone felt like that. I meant I was only climbing a flight of stairs when I was doing it, but everything else I was able to do normally. So when she went to India for a visit about 6 months later, she got a full checkup done because diagnostics are super cheap and easy accessible there. And on her echo, she was found to have significant rheumatic mitral valve disease with tricuspid valve involvement. She underwent mechanical mitral valve replacement, tricuspid annuloplasty, and is now on warfarin and antibiotics once a month. And that story kind of stuck with me because she's my age and these are patients that don't usually go to the doctor's office as often. So I wanted to talk about rheumatic heart disease in today's world. So these are the learning objectives for me: global burden of the rheumatic heart disease, pathophysiology, management, and treatment. So nearly a century after rheumatic fever and rheumatic heart disease was nearly eradicated from the developed world, the disease remains endemic in many, the disease remains endemic in many low and middle income countries with very grim health and socioeconomic impacts. With globalization over the last decade, there's been a resurgence of interest in rheumatic heart disease. It's one of the most critical forms of acquired heart disease in children and young adults living in developing countries. About 4.5 million people across the globe are affected, and it represents 1.6% of all the mortality from cardiovascular disease. Projections based on the study done on Global Burden of Disease survey in 2019 showed that in several developing countries, such as South Africa and India, it's still a primary concern, and that the case number of RHD in children has, in some areas, started to increase. Another study called the Remedy study, which is a global rheumatic heart disease registry, assembled a contemporary cohort of 3,000 patients in low to middle income countries. And it found that in this chart here, we can see that the age of patients were usually young, median age of 28 years, and they were mostly female, 66%. They're also largely unemployed. Another 10-year multi-center study done in the US in pediatric population showed that in patients in the US that presented with rheumatic heart disease, not just rheumatic fever, that rheumatic heart disease at the time of diagnosis were more likely to report travel to an endemic region. So about 13% of patients had known travel to the endemic regions, mostly the Pacific Islands, Africa, and the Caribbean. So RHD accounts for approximately 15 to 20% of all patients with heart failure in endemic countries. In this chart here, the endemic countries are shown as the larger circles, so mostly countries within Africa, Southeast Asia, India, China included here. An interesting thing in this graph or this chart is that the yellow and red colors on this map are countries where the prevalence of RHD has actually increased between 1990 to 2013. So South America, Africa, Asia, and then even some countries within Europe. So what is rheumatic heart disease? It is a disease that is the result of valvular damage caused by abnormal immune response to strep pyogenes infection. Which is classified as a group A streptococcus that causes acute rheumatic fever. Acute rheumatic fever itself occurs around 3 weeks after a strep pharyngitis infection. It can affect joints, skin, brain, and heart. After multiple episodes of rheumatic fever, progressive fibrosis of the heart valves can occur, which can lead to rheumatic valvular heart disease. And if the valvular heart disease remains untreated, we know that heart failure and death can occur. The exact precise pathophysiology of this is unknown, but this is what the thought process is. So on physical exam, we see symptoms often are like most cardiovascular symptoms, palpitations, dyspnea, fatigue, chest pain. On cardiac exam, it's usually based on valvular involvement. Mitral regurgitation is the most common presentation of rheumatic heart disease in young people. However, rheumatic heart disease is the most common cause of mitral stenosis worldwide. So in mitral regurgitation, you get a holosystolic murmur, may have a systolic thrill. Mitral stenosis has a pathognomonic murmur. It's a diastolic murmur following an opening snap. Bit audio for us here. The loud S1, the opening snap, and then a diastolic murmur. You can also see aortic regurgitation or aortic stenosis. Echocardiographic evaluation is the mainstay. So in 2023, the World Heart Federation, which is the cardiovascular branch of the WHO, released guidelines for echocardiographic diagnosis of rheumatic heart disease. The criteria for pathological MR requires all the following, and it has to be observed in 2 views. So the minimal mitral regurgitation jet area is 1.5 to 2 centimeters based on the weight of the patient, velocity of greater than 3 meters per second square, and a pansystolic jet. Similarly, for pathological aortic regurgitation, also should be observed in 2 views. You have a pandiastolic jet. For the morphological criteria of the rheumatic heart disease, when you're evaluating the valve itself, the mitral valve anterior leaflet thickening and/or mitral valve chordal thickening, mitral valve leaflet restriction, aortic valve thickening, prolapse, or restricted leaflet motion. Comes to the management and treatment. So medical management is similar. It's based on what stage of the heart disease a patient is in. Goal-directed medical therapy for heart failure management as much as possible, diuretics and antibiotics. The mainstay is benzathine, penicillin G, and we'll talk a little bit more about that later. But one big difference between this and Sept, my colleague will talk about nonvalvular atrial fibrillation later, but valvular atrial fibrillation is conventionally defined as atrial fibrillation in the setting of concomitant mitral stenosis or the presence of a mitral valve prosthesis. So there is increased risk of thromboembolic events compared to nonvalvular atrial fibrillation. The Invictus trial in 2022 showed that rivaroxaban is actually inferior to vitamin K antagonists in patients with rheumatic heart disease-associated atrial fibrillation. Vitamin K antagonist therapy led to lower rate of ischemic events and lower mortality due to vascular causes without significantly increasing bleeding. And patients of rheumatic AFib are more likely to have left atrial thrombi outside of the left atrial appendage compared to non-valvular AFib, which is also a significant difference. So one study showed that in patients documented to have left atrial thrombus, only about 57% of them had left atrial appendage thrombus. So for this reason, left atrial appendage closure with surgery or closure devices such as Watchman may be inadequate for stroke reduction. This next chart shows pattern of valvular disease by age group in patients without percutaneous or surgical intervention prior. So children in the first decade of life present predominantly with pure mitral regurgitation or with mixed mitral and mixed aortic valve disease emerging as the dominant mitral valve lesion from the second decade of life. The frequency of pure mitral stenosis, isolated aortic valve disease such as pure aortic stenosis, pure aortic regurgitation, or mixed aortic valve disease without mitral involvement is very low in early life and starts increasing with age. So for valvular interventions, based on studies of rheumatic valve disease, it's recommended that anatomical correction be performed before the onset of symptoms in patients that have severe mitral aortic regurgitation, guided by echocardiographic indices of left ventricular function. So in contrast to surgical closed mitral valve replacement, both percutaneous balloon mitral valvuloplasty and open surgical mitral commissurotomy produce excellent early hemodynamic improvement and are associated with lower rate of residual stenosis and restenosis and need for intervention. Though these both have good results, the lower cost and elimination of drawbacks of thoracotomy, cardiopulmonary bypass with cardiothoracic surgery indicate that balloon mitral valvuloplasty should be the treatment of choice for patients with a tight, pliable rheumatic mitral stenosis. There are no current transcatheter mitral valve replacement designs that are indicated for rheumatic heart disease, mostly due to the absence of annular calcification, which aids in the anchoring of this transcatheter valves. Another important chart is this, it's called the Wilkins Echo score. It takes into account calcification, thickening, valve mobility, and subvalvular thickening, and guides treatment options. So an echo score of less than 8 can be considered for percutaneous intervention. The other is, we talked about briefly, but open valvular surgery. In severe mixed valvular dysfunction and a symptomatic patient, surgery is indicated. Surgical options are recommended, especially when there's more than one valve involved. So you can do mitral valve repair or surgical mitral valve replacement. In mitral valve repair, the surgeon removes and repairs part of the damaged mitral valve to allow the valve to fully close and stop leaking in this picture here. The surgeon may tighten or reinforce the ring around the valve called the annulus and place an artificial ring called an annuloplasty band there. The long-term survival of mitral valve repair versus replacement in this chart here to the left is similar. However, the need for reoperation tends to be higher in repair than in replacement. If diagnosed early, definitive intervention is recommended prior to pregnancy in these patients. If pregnancy continues, beta blockers, diuretics for pulmonary edema, plus or minus digoxin is recommended. Surgery or percutaneous intervention is best performed after 24 weeks of gestation to minimize radiation risk and improve fetal survival if early labor occurs. If the pathology is very complex, such as they have multi-valve disease or calcified valves, conservative management is preferable because of the risk of fetal loss with cardiac bypass. There are guidelines for each valvular involvement, as listed here, but mitral stenosis is the one that has the most interventions that we can do percutaneously. These cases here are patients that I've taken from VCU where we actually do see some patients with rheumatic heart disease and that undergo treatment here. These cases were done by Dr. Gertz. So the first one is a 56-year-old female with a history of mitral stenosis, heart failure, undergoing mitral balloon valvulotomy. So we see here this patient has a mildly thickened, relatively mobile mitral valve that was free from calcium with a minimally thickened subvalvular apparatus with moderate to severe mitral stenosis and mild mitral regurgitation, making her Wilkins echo score 7, and she was able to undergo percutaneous intervention. So this first echo image shows there's a 26-millimeter inoid balloon that was manipulated across the atrial septum into position across the mitral valve, and a commissurotomy was performed with serial balloon inflations. This second echo is actually following the procedure. Mitral valve stenosis was reduced from severe to mild, and mitral regurgitation increased from mild to moderate, which is expected. The second case is a 68-year-old female with known history of rheumatic heart disease with mitral stenosis that presented with dyspnea. She also had a mildly thickened, minimally calcified valve despite her age, a relatively mobile mitral valve with relatively normal subvalvular apparatus. She had moderate to severe mitral stenosis and only trivial MR, and her Wilkins score was also 7. Following transcatheter valvulotomy, the stenosis became mild to moderate and regurgitation was mild. This is the procedure. Yeah. So screening for rheumatic heart disease, up to 1/3 of patients with acute rheumatic fever report no history of a sore throat, despite the existence of diagnostic guidelines for the millions of young people out there in the world who already have established rheumatic heart disease. Echocardiographic active case finding for mild to moderate disease appears to allow for early detection of rheumatic heart disease. Early disease, if detected, is when secondary prophylaxis with benzathine penicillin G has a higher rate of success, and screening can also help with timing of cardiac surgery so that surgery can be performed at an early stage of illness when outcomes of surgery are reported to be better. The World Heart Federation that I discussed earlier is the cardiovascular division of the WHO, released guidelines in 2023. They recommended more providers, non-experts, so non-cardiologists, perform basic screening ultrasound prior to a confirmatory echocardiogram, which are only available in developing countries in higher centers. So they developed echo screening criteria that can be done by non-experts. So a minimum mitral regurgitation jet of 1.5 to 2 centimeters present in at least one view, or an aortic regurgitation jet observed, any amount or restricted mitral valve leaflet motion with reduced opening, and very subjective findings that they can then go to a confirmatory echocardiogram. So the limitations on screening are many, but the biggest is the access to ultrasound machines. This chart over here on the left bottom shows the availability of ultrasound in low to middle income countries. It's not commonly available in the community, mostly in tertiary hospitals, usually of which there are only a handful per country. As you can see, it's mostly red in basic primary care, advanced primary care areas, and then catchment facilities, which are like 1 or 2 government hospitals within these countries, have ultrasound access. So it might not be as easy as just going out into the community and doing this. Once a confirmatory echocardiogram is done, we hope to identify patients in stages C and D that have advanced rheumatic heart disease when the patient is at high risk of developing clinical complications. If the echocardiogram does not show evidence of established rheumatic heart disease, we still need to look for evidence of pathological MR and AR. And we can find patients that are in stage B of the disease, which usually has mild rheumatic heart disease and are moderate to high risk to progression of overt rheumatic heart disease. And these patients we can more aggressively treat with antibiotics and things. So secondary antibiotic prophylaxis. Current American Heart Association guidelines recommend intramuscular benzathine penicillin G as the preferred agent for secondary prophylaxis with an every 4-week schedule for most individuals, though in high-risk patients or people who already have carditis can do an every 3-week schedule. These guidelines, as we can see, so American Heart Association recommends antibiotics until age 21. WHO back in 2004 recommended until age 25 for patients that do not have rheumatic heart disease, but evidence of some carditis. These guidelines are prior to 2010 and definitely need updating. The most recent international guidelines that I could find are actually from Australia in 2020. And they recommend classifying patients into mild, moderate, and high risk for rheumatic heart disease and using antibiotic prophylaxis from 25 to 40 years based on that. So what needs to be done globally? Strategies for prevention, control, and elimination of rheumatic heart disease consists of various levels of prevention. We are making advances in primary prevention involving early recognition of acute rheumatic fever and effective treatment of strep pharyngitis with penicillin. Although Dr. Gertz also commented and is curious what recent avoidance and trend in avoidance of antibiotics may play a role in the future. But planning, development, and implementation of a feasible program for the prevention and control of rheumatic heart disease should be an integral component of healthcare policy, especially in endemic countries. Those are my references. It's quite a few. But thank you all.
Thank you, Harika. What a wonderful
Yeah.
talk on.
Oh, Dr. Gertz is still here.
I
Yeah,
apologize.
sorry.
Thanks,
So I think we have a few more minutes before our next speaker. Does anybody have any questions for Dr. Yadav? What happened with your patient, Harika? Did you tell us?
The first patient or the ones
Yes.
the cases we did. Yeah, she got mitral valve so she got mitral valve balloon valvuloplasty first, and then had mitral regurgitation after that and tricuspid involvement because it just progressed apparently within that span of time, and so now she has mechanical mitral valve and tricuspid annuloplasty. Yep.
Great. Thank you.
Thank you. Thank you. Can I stop sharing, Shannon?
Yes, thank you.
Okay.
Thank you so much. We'll get on to our next speaker, and Dr. Connery will introduce her.
Good morning, everybody. Very nice talk, Harika. It's a real problem in all our when I was training. I remember having a post-bite balloon mitral valvotomy as my short case for oral exams. So that was our training for medicine. It gives me great pleasure. Yeah. It gives me great pleasure to introduce Angkawipa Trongtorsak. She is known as Sept to all of us. She is one of our cardiology fellows and has done internal medicine residency in Evanston, in Ascension St. Francis Hospital, and did her doctorate of medicine in Chulalongkorn University in Bangkok, Thailand. She has amassed quite a number of outstanding awards, both in clerkship as well as during her residency as an outstanding intern. Today, she's going to talk about drug therapy, especially anticoagulant therapy for atrial fibrillation.
Thank you, Dr. Konaru, for the kind introduction. Good morning, everyone. Today, I'm going to talk about stroke prevention. Stroke prevention in nonvalvular atrial fibrillation. Let's get started. The objectives are how to identify patients who will benefit from stroke prevention, types of anticoagulants that we can use in patients with nonvalvular AFib to prevent stroke, as well as what are other options we have if patients cannot tolerate anticoagulation. AFib is well known to be associated with an increased risk of ischemic stroke since the Framingham study in 1978. However, the risks of stroke are varied depending on risk factor. So identifying patients who will benefit from the stroke prevention is important. Here come to the score predicting stroke risk in nonvalvular AFib. CHAT score was the first score that was introduced in our practice in 2001. And the score includes congestive heart failure, hypertension, age at least 75 or above, diabetes, and stroke. The limitation of the CHAT score was the score does not reliably identify low-risk patient. As you can see in the graph, patients who have score of 0 still have stroke rates almost 2% per year in the real world. To address the limitation of the CHAT score, CHAT2 score was developed into our practice, and the score is the most validated score in our practice. CHAT2 score more reliably identify patients at low risk. As you can see in the graph, patients who have score of 0 or 1 was found to have annual stroke rates less than 1% in the real world. So the CHAT2 score is very good at identifying low-risk patients. However, the score is not perfect. The CHAT2 score have suboptimal performance in some populations, such as renal failure patients or Asian patients. Also, CHAT2 score is not as good as CHAT score on identifying high-risk patients. After CHAT2 score was introduced into our practice in 2010, new scores have been developed and may offer a potential benefit in specific population. For example, Atrial score include more age categories and renal function. Garfield AFib to include mortality and bleeding risk to facilitate this discussion with patients. However, those scores are not well validated in the real world. That is why CHAT2 score remains the standard score in our practice. And what about the recommendation for the stroke prevention on the new AFib guideline that was released last year? The guideline recommend anticoagulation if patients have annual stroke risk of 2 or above, which equal to CHAT2 score at least 2 in men and at least 3 in women. At this point, I think some people might have a question why we have different score in genders and why we still include female gender in the CHAT2 score. The answer is because female gender is a modified risk factor. Female gender have low risk if a patient doesn't have other risk factor, but female gender will increase risk of stroke when a patient have other stroke risk factor. And what about anticoagulation choice? The guideline recommend NOAC over warfarin if patient doesn't have mitral stenosis or mechanical heart valve. And aspirin is not recommended to prevent a stroke and is harm patient. And what about subclinical AFib that is detected in the device like the pacemaker, defibrillator, or holder? When should we start anticoagulation? The guideline mentioned that anticoagulation might be considered if patients have a subclinical AFib more than 24 hours and have a high risk of stroke. It is Class 2A recommendation. But anticoagulation is not recommended if patients have very short duration of AFib less than 5 minutes. And to make it simple, anticoagulation is not recommended if patient is low risk or if patient have the duration of AFib less than 5 minutes. In contrast, it is recommended if patients have high risk of developing stroke and very long duration of AFib more than 24 hours. And what about patient in the group B in the figure? Should we start anticoagulation or not? There are a couple of studies that have been studied in this group. The first study is NOAA AFib study. The study includes patients who have subclinical AFib at least 6 minutes and have CHA2 score at least 2. And the results show that the study compared between edoxaban and placebo. The results show that cardiovascular death, stroke, or systemic embolism was a little bit lower in the edoxaban group, but it's not significant. But the adverse outcomes were more common in the edoxaban group. The next study is Atrial study. This study also includes patients that have subclinical AFib at least 6 minutes to 24 hours to receive either apixaban or aspirin. The study showed that patients in the apixaban group have less stroke or systemic embolism significantly, but also have higher bleeding risk. Taken together, this data suggests that subclinical AFib increased risk of stroke. Anticoagulation might be able to reduce stroke risk, but it's also increased risk of bleeding. Shared decision-making with individual approach might be the appropriate method in this group. Let's move to the anticoagulants. The first agent that I want to talk about is warfarin. Warfarin was the first line therapy until the NOAC have come into our practice in 2010. But warfarin remains the first line therapy in moderate to severe mitral stenosis and mechanical heart valves. Also, it is the preferred agent in patients who receive cytochrome 450-3A4 inducing agent such as phenytoin or carbamazepine. When we talk about rheumatic heart valve and AFib or A-flutter, we have to talk about INVISTA trial. Harika already mentioned about this trial earlier. This trial random patients with rheumatic valve disease who have AFib or A-flutter to receive either rivaroxaban or VKA. And the study showed that patients in the rivaroxaban group have 25 higher rates of composite cardiovascular event and deaths compared to warfarin. So this trial was terminated prematurely. Realign trial compared dabigatran and warfarin in patients with mechanical heart valve. And the trial was terminated prematurely as well because patients in the dabigatran group were found to have higher stroke and bleeding rates compared to warfarin group. Moving to NOAC, let's start with mechanism of action of the NOAC. Rivaroxaban, apixaban, and edoxaban are direct factor 10A inhibitor, while dabigatran is a direct thrombin inhibitor. For the reversal agents, idarucizumab is approved for the reversal of dabigatran. And andexanet alpha is approved for the reversal of rivaroxaban and apixaban, but it doesn't have enough evidence to reverse the effect of edoxaban. So nowadays, edoxaban doesn't have a reversal agent. Move to each NOAC. Lilly trial compare dabigatran and warfarin in patients with nonvalvular AFib, and the study showed that dabigatran at higher dose 150 was superior to warfarin in reducing stroke, but have similar bleeding profile. While dabigatran at 110 milligram was not inferior to warfarin at stroke, and also have lower bleeding rates. Lockett AFib trial showed that levodoxaban was non-inferior to warfarin for the prevention of stroke or systemic embolism, and also that there was no significant difference in the bleeding. Aristotle trial showed that apixaban was superior to warfarin in preventing stroke or systemic embolism, and also have less bleeding. Engage AFib TIMI 48 trial showed that edoxaban was non-inferior to warfarin in preventing stroke or systemic embolism, and also have less bleeding. And what about pharmacokinetics? Levodoxaban and apixaban are metabolized by cytochrome 450, so there is concern for the drug interaction with medications that are metabolized by cytochrome 450, while dabigatran and edoxaban have less concern for the cytochrome 450 interactions. Moving to the dose of NOAC. Dabigatran, levodoxaban, and edoxaban dose need to be reduced based on creatinine clearance and are not recommended if patients have creatinine clearance less than 15. Also, edoxaban is not recommended if patients have creatinine clearance more than 95, because the study showed that edoxaban increased risk of stroke when compared to warfarin. For apixaban, the usual dose is 5 milligram BID, but the dose need to be adjusted if patients meet 2 out of 3 criteria based on Aristotle trial, which are S at least 80 or above, creatinine at least 1.5 or above, or body weight of 60 kg or less. If patient meet 2 out of 3, we have to reduce the dose to 2.5 BID. And another thing that I want to point out is the drug interaction. As mentioned before, apixaban is metabolized by cytochrome 450. So if patient take medication that are strong cytochrome 450 3A4 inhibitor, such as ketoconazole, itaconazole, or ritonavir, the dose also have to be reduced as well. Also, apixaban is the only NOAC that FDA is approved to use in patients with ESRD or creatinine clearance less than 15. But the Aristotle trial exclude patients who have creatinine clearance less than 25. So what is the right dose for this population? Renal AFib trial compare apixaban 5 milligram BID to warfarin in patients with ESRD on hemodialysis, and the study reduced the dose to 2.5 if patients meet criteria based on Aristotle trial, and the result showed that apixaban have similar rate of bleeding and stroke compared to warfarin in this population. The retrospective study that compared the dose of apixaban in patients with severe CKD that have eGFR less than 30, they show that patients who receive apixaban 5 mg BID have higher risk of bleeding compared to patients who receive apixaban 2.5 mg BID. But there was no difference in the risk of stroke, systemic embolism, or death. And moving to non-pharmacological stroke prevention. The guideline recommend percutaneous left atrial appendage occlusion in patients who have high risk of stroke, like moderate to high risk of stroke, and have contraindication to long-term oral anticoagulation due to non-reversible cause. Or it can be considered if patients have high risk of major bleeding. And there are many types of left atrial appendage occlusion as shown in slide. Devices that FDA is approved are the Watchman and also Emulet. And here at VCU, we do both Watchman and Emulet, and we have done more than 100 cases on the Watchman implantation. And thank you so much, everyone. I am open to any question.
Sept, what's your recommendation for end-stage renal disease? I didn't, and dialysis?
So right now we don't have enough data about the dose of the apixaban. FDA is approved apixaban for 5 mg BID for the ESRD patient, but some study review that 5 mg BID might have higher bleeding risk. So I think we still need more study to determine the dose of ESRD patient.
Thank you.
Currently, we actually recommend 5 unless they cannot take 5 hormone.
Sept, can you walk us through, if we're thinking about a Watchman device, what is the process that we work through here at VCU?
So if patient if we think that patient cannot tolerate oral anticoagulant, if patient have major bleeding, so we can refer patient to see us in the clinic for the shared decision making to see if patient would like to pursue the left atrial appendage closure or not, and then we can schedule patient to see EP and have scheduled to have the procedure. But before we decide to do the left atrial appendage closure, we also have to make sure that patient can tolerate short-term NOAC or anticoagulant as well.
And who do we refer to for that decision-making clinic? That's what that was sort of my question.
Can I help?
Yeah.
Sept, can I talk?
Sure.
Yeah. So couple of things. They don't currently need to be able to take NOAC because the current devices, we just give aspirin and Plavix for 6 months. Or a half-dose Eliquis and baby aspirin. Both have been shown to be okay. So if somebody shows up in clinic with 2.5 milligrams of NOAC, we continue that post-procedure. So, or the current devices, especially the Watchman Flex Pro, you can just do aspirin and Plavix for 6 months, likewise with Amulet. Now, if you see somebody in clinic that requires some discussion regarding left atrial appendage management, it could be subtle sometimes. People show up with complete ecchymosis all over their body, like bruising, like horrible bruising. And that previously did not used to be a compelling indication, but nowadays insurance companies are accepting that as an indication. And falls, frequent falls, recurrent epistaxis, unexplained anemia, spinal injections for pain, for osteoarthritis, these kind of things. The referral should be to a shared decision-making clinic visit with one of the non-invasive cardiologists. Could be any of our non-invasive colleagues, but not to interventional colleagues. So it can be anyone who doesn't do intervention or EP is okay to do a shared decision-making visit. And that can be documented. The specific verbiage is listed in the ACC shared decision-making toolkit. So we can, when we document for insurance purposes, the documentation should include verbiage like I visited with the patient and had a formal visit, which included the ACC AHA shared decision-making toolkit, and the patient and I agree that this is an appropriate option. And then the EPs are just what we do, or just a technical aspect explanation to the patient, and discuss with them what the pros and cons of each device are, those kind of things. But it can be any non-invasive cardiologist.
Very good.
And very
Hi,
nice.
everyone. Oh,
Yeah, go ahead, Sean.
my apologies. There was a question in the chat for Harika. Harika, if you're still on, Dr. Hayter asked about what is the anticoagulation throughout the 3 trimesters of pregnancy? What are the recommendations?
Oh, so that obviously isn't studied very well, and but I do believe that it's similar, like pregnant versus non-pregnant females, the anticoagulation regimen is similar. However, like similar to rheumatic heart disease versus if you're doing a mechanical valve. But so warfarin is contraindicated in the first trimester for sure due to fetal abnormalities. So I think they recommend switching to low molecular weight heparin or unfractionated heparin if possible throughout the pregnancy. But if needed, then I believe after the second trimester, warfarin can be used, but still comes with higher bleeding risk and risk of fetal complications. Sorry, I don't know the complete answer to that.
Thank you. I believe that there's one more question, and it's from Dr. Sadiq that's directed towards Sept. Is there any guidance on anticoagulation for AFib duration for more than 5 minutes, but less than 24 hours?
So right now is no clear recommendation. It's going to be shared decision making with patient because because from the 2 study that we have, patient who have AFib about 5 minutes to less than 24 hours, starting anticoagulant can reduce the stroke risk, but also increase the risk of bleeding.
Our recommendation
Thank
has always, in this case, because we deal with this very frequently, when we do remote monitor, somebody shows up with 6 hours of AFib, a singular episode. So in those patients, if it is a singular episode, we don't, and if the patient is 90 years old, all these factors come into play. And the NOVA AF NET and the Artesia studies really let us open our eyes, because we used to knee-jerk reaction-wise give them all anticoagulation, and that has changed significantly with the publication of these studies. Now we are a little bit more nuanced in our decision-making.
Well, thank you both for a wonderful talk. I learned so much from both of you. And you were finished on time, answered all the questions. Thank you to Dr. Gertz and Dr. Conneru for introducing and mentoring our concept. If there are no other questions, we will end Grand Rounds early today. Thank you.
Thank you.